Cervical lymphadenopathy and difficulty breathing. Scenario: a 30-year-old man presents to the emergency department on Christmas Day complaining of increased difficulty breathing over the last week. Today he could not swallow his dinner. He has noticed some lumps in his neck. Introduction. Dyspnea can be difficult to assess, but in previously fit individuals this symptom should always be taken seriously. Cervical lymphadenopathy is a common clinical problem. Most cases are due to common viral infections, but nodes over 1 cm in size that persist for over 2 weeks should be considered for referral, in the UK, under the 2-week cancer rule, to either a hematology or ear, nose, and throat, and department if above shoulders or to GS if below the shoulder. NB. In cases of breathlessness in a patient with cervical lymphadenopathy, always consider upper airway obstruction, which is a medical emergency. History of the presenting problem. Breathing. Aside from general inquiries to establish the degree of breathlessness, do you normally have any problems with your breathing? What makes you breathless? Is there a change in exercise tolerance or are you short of breath at rest? Ask specifically about the problem of dysphagia and lumps in the neck. Do you feel as if you are choking or have you inhaled anything? Because there is clearly the potential for upper airway problems. In addition, ask about any problems with the throat, sinuses, or ears, sites of local infection, any change in voice, suggests laryngeal problems, and hemoptysis, indicates lung cancer or tuberculosis. Dysphagia. The history given suggests that this has been a problem today, but has he had previous difficulties? Lymph nodes. Ask the patient the following questions. How long have you had the lumps in your neck, nodes? Have they been present before? Are they changing in size? Decreasing size is usually reassuring, whereas increasing size alerts you to a progressive problem. Are they painful? Painless nodes are more ominous than pain associated with infection. Do you have any other lumps, glands? This would suggest a generalized process. General features. Has the patient undergone any weight loss? This could be a feature of infection, tuberculosis, or malignancy. Also, has he had temperatures or night sweats? These are obviously a feature of infection, but intermittent persisting fever suggests lymphoma. Has he or any of his contacts had tuberculosis? This remains a cause of nodes and dyspnea. Other relevant history. Inquire about the following. Has the patient had any headaches? This is a feature of superior vena cava, SVC, obstruction. Has he been to the tropics? This broadens the infectious possibilities. Has he had any tumors or cancers in the past? Is he on any medication? Some drugs, e.g. phenytoin, can cause lymphadenopathy. Has he had arthritis or skin rash? Systemic lupus erythematosus can cause nodes and dyspnea. Examination, general features. Assess the patient for the following. Distress and anxiety. How is he breathing? Is there stridor? Can he talk and, if so, is his voice normal? Is he dribbling/drooling? This is a significant sign suggesting that he is unable to swallow secretions easily, and may have critical compromise of the airway. Check his vital signs, temperature, pulse, BP, respiratory rate, and pulse oximetry. Pallor. Cyanosis. Pharyngeal swelling or infection. Look carefully, but if a patient has stridor or is dribbling, do not ask them to open their mouth as wide as possible, as this may make a critical situation worse. Features of SVC obstruction. Look for swelling of face and arms, jugular veins that will probably be prominent and non-pulsatile, and for superficial collateral vessels that may bypass the underlying venous obstruction. Examination: respiratory and reticuloendothelial systems. Test for stridor by asking the patient to open his mouth and take a breath in and out as fast as he can, if necessary demonstrate, and get him to repeat. Localize the trachea. Is expansion equal? Percuss and auscultate the chest for consolidation or fluid. Examine the cervical nodes from behind the patient, including an assessment for thyroid swelling. Examine the axilla and groin systematically. Is there hepatosplenomegaly or nodal masses within the abdomen? Investigation. NB. If a patient is extremely ill, then resuscitation must be started before investigation. If the patient's breathing is severely compromised, then the immediate priority must be to secure the airway. If necessary, this must take precedence over investigation. NB. Management of critical upper airway compromise. Sit the patient up. Give them high-flow oxygen. Call immediately for help from an anesthetic or ENT specialist. If the situation with the airway is not critical, or when the airway has been secured, then appropriate investigations would include the following. To determine the cause of lymphadenopathy, FBC and film may reveal features of lymphoma, Fig9, clotting screen, biopsy likely to be needed, electrolytes and a biochemical profile. Hypercalcemia is a feature of several conditions that can cause lymphadenopathy. Also check viral serology, tests for other infectious conditions and serological tests for autoimmune rheumatic disorder if clinically appropriate. Perform a CXR, looking in particular for hilar/nodal swelling, Fig10, or lung cancer. It is probably best followed by CT scan of the chest, and possibly abdomen and pelvis, and possibly by bronchoscopy, if indicated. ENT referral for laryngoscopy will be appropriate if the lymphadenopathy is confined to the patient's neck. The single investigation most likely to establish the diagnosis is obviously lymph node biopsy. This will often be by fine needle aspiration, but excision biopsy will be required for full lymphoma histology. To assess respiratory compromise, arterial blood gases, lung function tests and, in particular, flow volume loops. Management. As described above, if a patient with cervical lymphadenopathy has severely compromised upper airway, then securing the airway is the first priority and takes precedence over investigation. Definitive management depends on the cause, but is the same as for SVC obstruction. If cervical lymphadenopathy is causing airway compromise, then steroids, dexamethasone 10 mg 4, followed by 4 mg PO/QDS, can provide some relief, but it is best, if safely possible, to obtain diagnostic tissue before doing this, as lymphoma is very sensitive to steroids and treatment may compromise making the diagnosis.